Good evening, good evening.
Rahul Khanna sir, namaskar.
Khanna
Namaskar,
sir, good
sir.
evening, sir.
Khanna sir,
Rahul sir,
namaskar.
good evening.
Namaste, sir.
Sir, namaste.
With the permission of the faculty, we will call the lesson in order, and we will wait for the other faculty to join as they join. But it's already 8 o'clock. Dr. Suyash, please start or share your PowerPoint.
Yes, sir.
Good evening, friends, both in Zoom and as well as YouTube. Today we have a multinodular goiter. The postgraduate Dr. Suyash Bansal is kindly contributed by Professor Sriram Bhatt, the most eminent author, textbook author, and he is currently head of the department at Kasturba Medical College, Mangalore. And we have a very eminent faculty panel today. In fact, I should thank Dr. Nishikant for taking all the efforts to bring in senior people. Professor Narendra Gupta, he himself is an eminent cardiovascular surgeon and he heads the Department of Surgery at Hind Institute of Medical Sciences at Sitapur. And we have other faculty for the day. We have Dr. Abhinav Shankar, is expected to join shortly. And we have Professor Goitre Madam, Head of the Department at Stanley Medical College. Professor Pabita Ma'am from Tirunelveli Medical College. And I think Professor Mukesh Overa is still not completed his case, so he may be joining little later. So without much ado, I also duly respect the presence of the senior teachers of our own PG clinics, Professor Khanna sir, Professor Srinivasan sir, and other senior professors who have been with us for the past 4 years. Friends, this is our almost 275th session. So we have 475 cases which are available in the YouTube. So those who wish to join us are welcome to come as a faculty or join us as a presenter. So you are welcome to do that. All the older classes are available in the YouTube for your benefit. So warm welcome to all of you. Dr. Suyash, please introduce yourself, your unit chief, and you are head of the department and start your presentation. Faculty here, kindly note the student will be allowed to present all through without stopping through the history part. Then you can visit all the slides to ask questions. Then they move to the clinical part without stopping, they'll complete. And then you can rework on every slide to give your comments or ask your questions. A gentle request to all the faculty, if there is a trouble the student is facing or anything, I would request you to kindly allow them to know the right answer, and that will be of much use to the students. I could see Professor CMKR sir, very eminent professor from Government Stanley Medical College. I would say teacher of teachers. Thank you, sir, for joining this evening. So, Dr. Suyash, please switch on your video and start your presentation. Good luck to you.
Yes.
Faculty, kindly take over.
Thank you, sir. Good evening, one and all. My name is...
Suyash, we are
Yes,
unable
sir.
to see you. Can you just check that first?
Yes, sir. Sure, sir.
I think now we are okay. Rajgopal sir, good evening, sir.
Good evening. Good evening.
Yes, sir.
Sir, good evening, sir.
Kanakvel, good evening.
Good evening, good evening.
Good evening. Good evening. Good evening, sir. Yes, sir.
Good evening, sir.
Carry on. Carry on.
Professor CMK sir, good evening, sir. Please start your presentation, Suyash. We are again lost your video, ma. Please check. I think there is some connection issue.
So is it visible now, sir?
No, your slides are well. Now it is okay, but again we have lost. Please
sir,
check one now.
Yes.
Yeah, you are okay now.
Yes, sir.
Please start your presentation, ma. We are already 5 minutes delayed. Please.
Yes. Am I visible right now, sir?
Perfect, perfect, perfect. Please go.
Yes. Good evening, one and all. My name is Suyash Bansal. I'm a third year junior resident in Kasturba Medical College, Mangalore. I'm presenting this case under the guidance of my... Am I audible, sir?
Yes.
My unit chief is Dr. Sriram Bhatt sir, and I'm presenting under the guidance of Dr. Ashfaq Mohammed sir, head of Department of Surgery, KMC Mangalore. We had a 53-year-old female, a daily wage laborer by occupation hailing from Davangere, Karnataka, who presented with the chief complaints of swelling in the front of the neck since 8 years. The patient came with complaints of swelling in front of the neck, which was insidious in onset, gradually progressive in nature. It was initially about 2 into 2 centimeter in size, and then it progressed and attained its present size. The swelling was not associated with pain, and the patient did not give any history of dysphagia or hoarseness of voice. The patient also complained of bilateral lower limb swelling since 2 months. It started around the foot region, which then gradually ascended till the mid-thigh level, till the thigh level. She also complains of loose stools, about 10 to 15 episodes per day, heat intolerance, preference for cold, excessive sweating, increased appetite, unintentional loss of weight, tremors, and she also complains of breathlessness after walking for a distance of about 500 meters. Coming on to past history, patient underwent a needle test 7 years back in Bangalore and was advised medication. She is a known case of hyperthyroidism since past 10 years and is on the treatment for the same. She stopped her medication for for a period of 3 years and then restarted it a year back. She is presently on tablet carbimazole 20 milligram BD, and other surgical histories that she underwent tubectomy 25 years back. Patient is not a known case of hypertension, diabetes mellitus, asthma, or any cardiac comorbidities. There is no history of thyroid malignancy or thyroid swellings or similar complaints in the family. Coming on to menstrual history, patient attained menarche at the age of 14 years. She had regular cycles of about 28 days, which lasted for about 4 days. The flow was moderate and it was regular, requiring 2 to 3 pad soakage per day. She attained menopause 10 years back. Patient has one child, male child, full-term normal delivery. Coming on to personal history, the diet was predominantly, she predominantly consumes a non-vegetarian diet. Appetite is increased, sleep is disturbed, bowel movements have increased, while bladder movements are unremarkable. Coming on to summary, it is this presenting a 53-year-old female, a known case of hyperthyroidism, who presented with a swelling in the front of the neck since 8 years, not associated with pain, and having features of thyrotoxicosis.
Okay. In the history, Mr.
Yes, sir.
Suyesh, Dr. Suyesh,
Yes, yes, sir.
ask the patient which side does she notice the swelling first, because now there may be bilateral, but
Yes, sir.
initially there may be only one side. She may be able to say, yeah, it started on the right side, now it
Yes,
is
sir.
on both sides. You can't say that by physical examination, you can't say that. Only history can
Yes,
tell
sir.
you that.
Yes, sir.
That's one thing.
The page, yes, sir.
Second is, why do they lose weight in thyrotoxicosis?
Patient has an unintentional loss of weight, sir.
Why do
Even
they
with
lose weight in thyrotoxicosis is the question.
The
You have to
metabolism,
know a little bit of physiology. All these
metabolic,
things.
yes, sir.
Huh?
The basal metabolic rate is high, sir.
Metabolic rate is not correct, because a growing child has a high metabolism, pregnant woman has a high metabolism, but they don't lose weight.
Yes,
You
sir.
break the metabolism into 2 parts, then you get the answer. Catabolism.
Yes, sir. Patient will be
Increase
in a
the
catabolic state,
catabolism.
sir.
It's a thyroid is a catabolic hormone.
Yes,
That is
sir.
the answer. Okay, carry on.
Yes, sir.
Any other
Yes.
questions from the faculty, please?
No, he
Yes.
said unintentional. What do you mean by unintentional and intentional weight loss?
Good evening, Dr. Srinivasan. Good evening.
Good evening, sir. Good evening, sir. Nice to see you.
Yes, yes. Good evening.
Still looking the young.
Yeah, I know.
What do you mean? Yes, no problem.
Sir, even with the normal appetite, sir, the
It's not
patient is having
unintentional,
loss
it's
of-
unexplained. That is the correct word.
Okay, sir.
So Suyash, how was
Unexplained is the
height?
correct word.
Yes,
He was losing weight.
In spite
How
of
was that
normal
height?
appetite, he is losing weight.
Okay.
yes, sir.
Uh,
Unexplained weight loss. Okay.
Yes, sir.
Patient
is she
doesn't have
still losing weight?
doesn't have appetite, doesn't have then loss of weight means that means there is something, because
So that means her thyrotoxicosis is not controlled,
Yes, sir.
or her hyperthyroidism is not controlled, how much weight loss is there over how much time? Is she continuing to lose weight from the very beginning, or is it a recent phenomena?
So I think that the thyrotoxicosis is not controlled since she stopped taking medication for about 3 years period, sir, and then
No,
restarted a year
no,
back.
no, no. She stopped, but he said she has started
Restarted.
carbimazole for 1 year.
Yes, sir. But that weight loss has continued, sir.
What about tremors? Did you check for tremors?
Yes, sir. That I've mentioned during general physical examination, sir. In that I've mentioned that fine tremors were present, sir.
Okay.
Suyash, what other
How do you know?
medications?
How do you know that she is taking carbimazole?
So she showed me the medication, but coming on to history, usually patient tells that she's taking medication for a thyroid disease about twice or thrice a day. If
No,
she's taking
after taking these
supplementary,
drugs, what are the signs of well-being to know that the toxicosis is getting controlled or diminished? What are the signs you look for? Signs or
her
symptoms?
irritability or excitability will decrease. The tremors will subside, sir.
Tremors late pa.
Um,
Sense of
if
well-being.
she's having
Pulse rate.
palpitations,
Pulse rate or appetite will be all these things. Okay.
yes, sir.
Suyash, which other medication goes hand in hand with carbimazole usually? Patients getting carbimazole.
Yes,
Which
sir.
other medication usually goes hand in hand with that?
Propranolol also,
Yeah,
like
beta
beta
blocker.
blockers can be given
So
along with
was she
that, sir.
taking that beta blocker?
No, sir. She only showed us
हमारे
one
चैन मैंने
medication.
यूज कर लिए और यार दिल्ली के इस चलने का मजा ही अलग
So uh,
Yes, sir.
would beta blocker have what advantage would beta blocker provide over carbimazole?
नहीं चला
So beta blockers will reduce palpitations, sir. The tachycardia will subside. It also causes it also decreases peripheral conversion of T4 to T3, sir.
Carbimazole is a
Active
centrally
metabolite.
acting drug. Centrally acting drug. The beta blockers are peripherally acting drugs.
Yes.
What are the toxicities of carbimazole that we have to look out for? She's been taking it for 3 years, isn't it?
Yes, sir.
So what are the
Carbimazole is
toxicities
also a
associated with
goitrogenic
carbimazole?
drug, sir. Carbimazole or propylthiouracil, these are also goitrogenic drugs. They may also cause
Quatergenic.
Which group of drug is that? Carbimazole comes under what group?
And this is an antithyroid drug, sir.
It's an immunosuppressant because it's an autoimmune disease. No, it's an immunosuppressant.
Yes.
Yes. Okay. Carry on.
Suresh,
Yes, sir.
Suresh,
Yes,
you have
sir.
mentioned that the patient is complaining of loose stool.
Yes, sir.
In which thyroid condition will get the loose stool? What are
So
the
in cases
conditions of the thyroid? No, I am
in
asking in
thyrotoxic-
relation to the thyroid. In which condition will get the loose stools?
So in hyperthyroidism, sir, usually patient presents with loose stools, sir.
Hyperthyroidism. One more condition in which presenting symptom is a diarrhea.
So Graves' disease, sir.
No. What is cause of diarrhea in case of hyperthyroidism?
So the intestinal motility is increased, sir.
Any other condition of the thyroid that present with the diarrhea? Any malignancy of thyroid?
So I'm not sure, sir.
How the
Suppose the
medullary
patient has
thyroid?
mass and his main complaint is diarrhea, sweating, flushing? What do you suspect? Sarah is giving you a lot of clue. That is another patient with a malignancy.
Yes, sir. So in case of medullary carcinoma thyroid, sir.
So what is difference between these two? Why there is diarrhea in case of medullary carcinoma thyroid? It is a secretory diarrhea.
Okay, sir.
Okay, proceed.
Should I go ahead with examination, sir?
Yeah, proceed with the physical examination. Yeah.
Coming on to general physical examination, sir. Patient is a thin-built and poorly nourished female, conscious, cooperative, and well-oriented to time, place, and person. Pallor is present. There was pitting pedal edema extending till bilateral mid-thigh level, sir. The pulse rate was 98 beats per minute, regular in rhythm and normal in volume and character. Blood pressure was 110 by 70 millimeters of mercury in right arm sitting position, and the respiratory rate was about 14 cycles per minute. And coming to eye signs, lid retraction was noted, sir. Coming on to local examination, patient was examined in a well-lit room with due consent in the presence of a female bystander. The patient was examined from the back with the patient in sitting position and neck in flight flexion. On inspection, a 6 into 7 centimeter butterfly-shaped swelling is noted over the anterior aspect of the neck. It extends superiorly till the thyroid cartilage and inferiorly 2 centimeters above the suprasternal notch. Horizontally, it is 1 centimeter medial to the middle border of the right and the left sternocleidomastoids. The surface appeared nodular. Margins were well defined. Sir. The swelling was moving with deglutition. The lower border was visible. There were dilated veins noted over the skin of the swelling. There were no scars or sinuses noted, and the trachea was not visible. On palpation, there was no local rise of temperature and tenderness was absent. All inspectory findings were confirmed. The consistency was firm, nodular surface was present, and a 2 into 2 centimeter nodule was noted over the right thyroid lobe. Sir. The margins were well defined. The lower border was well felt. Skin over the swelling is pinchable, and the plane of the swelling is deep to deep cervical fascia. Swelling is mobile horizontally and vertically. The trachea was central. Both the carotid pulsations were not displaced, and there was no palpable cervical lymph node. On percussion, there was a resonant node noted on the manubrium sternum, and on auscultation, there was no Breuer. The skull and spine was normal. Oral cavity was normal.
That's okay. What is it? A single nodule? You felt only one nodule?
So I felt multiple nodules.
You mentioned only one nodule, no?
The surface was nodular, sir.
No, palpation.
On palpation, sir, I felt multiple
only
nodules.
one nodule.
Yes, there was.
Go to palpation.
Yes, sir.
Yeah, surface nodular and only one nodule, 2 to 2 centimeter nodule, right thyroid lobe. That means it is only one nodule. There are multiple nodules, you should say both sides, and you're approximately ranging from 1 to 2 centimeters, something like that, no?
Okay, sir. Yes, sir. Yes, sir.
You say nodule, what does that mean? There's only one nodule.
Yes. No, sir. I wanted to say that.
Why did you say that the plane is deep to the cervical fascia? What makes you say that? One statement you made that the plane of the swelling was deep to the deep cervical fascia. So how do you say that?
On putting the platysma on,
Doctor,
on putting the...
No, even on inspection, the fact that it's moving with deglutition, it is deep to the fascia only. Something outside the fascia can't move with deglutition, no? So even by inspection, you can say that.
The pretracheal fascia will move with deglutition, sir. So the swelling is probably deep to the pretracheal fascia.
Okay. So there are nodules both sides.
Yes, sir. Multiple nodules are palpated, sir.
But you didn't mention that, no? Very important, because that makes a difference in terms of management.
Yes, sir.
Okay.
Why did you percuss the manubrium sterni?
if there is a dull node palpated on percussion, it might be a mediastinal lymph node, sir, or retrosternal extension of the thyroid swelling, sir.
See, Manubium sterni is what? It's a bone, isn't it?
Yes, sir.
So if you percuss over a bone in any
Yes, sir.
circumstance, can you get a resonant node at all? It's not possible, isn't it? It should always be dull.
Yes, sir.
It's a fairly thick bone. It's about 1 centimeter thick. It's not a papery thin bone. Okay.
Yes, sir.
It's
Yes,
going
sir.
to be dull always. So
Yes, sir.
it's not relevant.
Yes, sir.
You said lower border is palpable, isn't it?
Yes, sir. Yes, sir.
Then how do you look for, why do you want to look for the retrosternal extension?
Exactly.
Yes, sir. Yes. Lower border is palpable.
See, as a postgraduate, I'll tell you the answer because you
Correct.
may have a primary retrosternal goiter or intrathoracic goiter or a secondary from the neck into the one. For that, you have to palpate along the parasternal space, not along the retrosternal space, over the mandibular sternum. Okay,
Okay, sir.
that's one. But it's not confirmatory, as Professor Rahul sir said. It's not confirmatory, but you have to do it. Even if the lower border is visible, you have
Yes,
to
sir.
palpate and look for any primary intrathoracic goiter.
Okay, sir.
Professor Reddy has given a rule of one.
Rule of one.
For retrosternal goiter.
Yeah, 1% are retrosternal, 1% are malignant, only 1% requires sternotomy.
Okay.
Very important. Yes.
Suyesh,
Yes, sir.
you have mentioned that surface is nodular. What is the meaning
Yes,
of nodular surface and what is the meaning of bossulated surface when it is called as nodular surface?
If multiple nodules can be palpable, sir, the surface would appear nodular. If there is a large swelling, it usually goes towards bossulated, sir. So large swellings will on palpation will appear bossulated, sir.
Nodular mean?
Multiple nodules on palpation of the thyroid, sir.
You have not got
And
the
bossulated?
question. The question is
Actually,
what is the
difference-
difference between nodular surface and bossulated surface? That
Yes,
is
sir.
Professor Nishikant's question.
Yes, sir.
Yes, in the beginning you said that lid retraction was seen, but
Yes,
in the
sir.
photograph we saw there was no lid retraction. If you go back to that photo, why did you say there's lid retraction? If you go back to the original photo of the
Yes, sir.
patient,
Yes, sir.
yeah. What makes you say there's lid retraction in this photograph?
On while examining, sir, the upper eyelid was the sclera was visible, sir. So because of that, I
Where it's not
mentioned
visible.
that
Upper eyelid is covering the iris.
it's in this
You can't
photo.
see the
Yes, sir.
sclera over there.
Yes, sir.
Whose sign is it? Whose
In this
sign
photo,
is
it's
that?
not there.
Right.
What is the sign called? Let me see the
Dalrymple sign will be lid retraction, sir.
Whose sign is
Dalrymple
this?
sign.
Whose sign is this?
So
you think
Dalrymple sign
is
will be
positive?
lid retraction.
No. This lid retraction is vangraphy.
So,
No?
Yes, sir.
What is the explanation given?
It is because of hyperactivity of the levator palpebrae superioris, sir.
The entire muscle? Levator valve superiority is oculomotor now.
Yes, sir.
How does that has to do with thyroid?
Autonomic hyperactivity will be there, sir.
No. Then that should be there for all muscles. No, why only one muscle? There is a component of superior palpebral that's called Miller's muscle.
Okay, sir.
That is supplied by sympathetic system, cervical sympathetic.
Okay.
You got it?
Yes, sir. Yes, sir.
Not the whole levator palpebrae muscle.
Okay, sir.
Miller's muscle component of levator palpebrae muscle. Okay.
Yes, sir.
Suyesh,
Yes, sir.
okay,
Yes.
go ahead. Go.
nodular surface means presence of distinct nodule. And
Okay,
bossulated surface describe a general rough or lumpy texture. This is the difference between these two.
Okay,
Okay.
sir.
That's it.
Yes.
Dr. Suyesh,
Yes, sir.
Can you just put me that palpation slide, please?
Yes, sir.
Yeah, just. It's better that you. What is the method you palpated? In which you have palpated the swelling? It looks basic, but I think it's worth mentioning.
I palpated from the back of the patient, sir.
So that's called
When
as a classical method. So in which you start palpating the thyroid gland. Okay. First
Yes,
thing.
sir.
Second important thing, just to add you on inspection wise, the photograph what I see in front of mine now,
Yes,
and
sir.
any other means you do so that thyroid gland looks more prominent. It's very important. You may be knowing WHO grading of the thyroid enlargements. Doesn't matter, but how to make this gland look more prominent on inspection right in front of me.
On
Yes.
slight extension of the neck, sir, the thyroid will
Don't
be
have
more.
to worry about slight, just say extension of the neck. Why it becomes more prominent? It is true, correct. Yes. You see all the thyroid glands you see in the warts, they look very prominent when you extend the neck because
The
some
deep
amount of
fascia is.
not dysphagia, cervical lordosis.
Yes, sir. Yes, sir. Sorry.
Like a
Because of
terminus
cervical
water,
lordosis.
arithmetic pushes. So that is one thing, number one. On inspection wise, even without that, I can see some finding. Probably, I'm not sure whether you mentioned there is a
Yes, sir.
very prominent on the right side. Did you mention that?
Yes, sir. I've mentioned, sir.
Show me
There
that.
was.
I might have missed
See,
that.
he has not commented on lateral movements. More lateral mobility has not commented, and on protrusion of tongue, he has not mentioned what happens. And then about lymph nodes, he has not mentioned.
Yes, sir. Sir, just 1 minute, sir. So what I want just to clarify, just go back. Just one slide, please. The
Yes,
first
sir.
thing you should mention is what is palpable. See, you know that thyroid has got right lobe, left lobe, isthmus, everything.
Yes.
The
Yes, sir.
moment you say one nodule is palpable, this becomes surface is smooth. If you say more than one nodule, two nodule, they collectively form a nodular surface. Number one. Number
Okay.
two, if you say left lobe is not enlarged, isthmus is not enlarged, your diagnosis becomes solitary nodule.
Already. Yes.
If you say left lobe is enlarged, your diagnosis changes. So it is so important in the clinical examination to mention. I
Yes.
start palpating from behind. First, what is palpable? Where to say. On right
Yes.
side, whatever you said. Sir, please take over, sir. Dr. Narendra Gupta, sir. Sorry.
Yes. So both the lobes and the isthmus were palpable, sir. Yes, I should have mentioned. So mobility, I've mentioned, sir.
Dr. Shanai, please unmute yourself here.
Thyroid has how many lobes? Is there any other
Carry
additional
on.
lobes? Additional lobe
Carry
is
on.
there?
Let him carry on. We'll discuss later.
Pyramidal lobe is.
In which condition you are going to expect the pyramidal lobe more? So usually in Hashimoto's, there is a more possibility of having a pyramidal lobe will be also enlarged more. Bosselated is only a bumpy humpy surface. I mean, it is like a bumpy hump. It not present a nodule and pit. The pit and valley is a feature in the nodule. You can see a nodule, then go for the pit, then N comes. Then only you must talk it as a nodular surface. Otherwise, the surface like this, it is only a bumpy humpy surface. That should be talked as a bosselated surface.
Finish your examination findings now, Suyash.
Sorry, sir.
Have you finished your examination findings, or do you want to?
Yes, sir. Finished. Just systemic examination was pending, sir. Systemic examination was normal, sir.
Okay, carry on. Go to the next slide.
Did you
Like to give a sorry, sir.
did you mention trachea, carotid, all that things?
I have mentioned.
See, show me that slide. Yeah.
Trachea was central, sir. And both the carotid pulsations were not displaced, sir.
Shays, where do you get the trachea? Trachea starts from where?
So second or third tracheal rings will be palpable, sir.
No, my question is, and from where is trachea starts? What is the landmark of trachea starts? Where the landmark of esophagus starts, both are the same level or different level?
C6 level, sir.
Okay.
Have
Have you checked for the trachea?
Yes, sir. Trachea was palpable, sir, with trail sign. Although isthmus, the lower
Yeah.
border.
Trail sign is not a palpatory sign; it is an inspectory sign.
Okay.
So it is one of the very common thing which you always miss. Even a large nodule, you'll say the trachea I have seen. It is very difficult to see a trachea in
On
this case.
inspection,
You can't
yes,
feel the trachea here.
yes, sir. On inspection, the trachea was not visible. On palpation, I've mentioned that trachea was central.
Trachea is visible on palpation.
No, sorry. On inspection, the trachea was not visible, sir. On palpation, I've mentioned that it was
Your
central.
entire mass is coming up to the sternal notch. Where did you feel the trachea then?
Okay, carry on. Next.
When you make a statement, mobile horizontally and vertically, it's not correct. What did you understand by that sentence? Is it intrinsic mobility you are talking or independent mobility? Is it like a fibroadenoma you are describing, or is it like thyroglossal cyst you are describing, or what is it? What did you mean by that sentence?
The thyroid swelling was not fixed, sir. Fixed thyroid.
Can you move this whole thing like horizontal and vertical, just like a?
No, sir. No, sir.
So what happens when you try to move the thyroid gland horizontally? You try moving your thyroid gland horizontally. It usually moves along with the trachea, correct?
Yes, sir. Yes, sir.
So it is not independent mobility you are checking here. Is it okay? You understood what I'm telling?
Yes, sir. Yes, sir. Yes, sir.
It has to move. The whole process. A nodule which is anaplastic carcinoma.
Yes, sir.
You understand?
Somebody voice is hearing. Please unmute yourself. Okay.
Yes, you carry on. Suyesh, carry on.
Yes. Yes, sir. I would like to give a provisional diagnosis of toxic multinodular goiter in hyperthyroid state, sir.
Okay.
So you can get a toxic thyroid in any other state?
Do you have any differential diagnosis?
No, sir. This was the only provisional diagnosis I could think of, sir.
See, there are three components in the diagnosis, rather four components. One is the anatomical involvement of the gland. Second is the functional status. Three is the pressure symptoms, signs, or pressure effects. And fourth is whether it is benign or malignant. So you got to answer all the four. Here we noticed that you answered two types. Okay, that it is multinodular and hyperthyroid. What about the pressure effects? What about whether it is benign or malignant? These two also you need to answer in the diagnosis.
And you must also say which type of hyperthyroidism he is having. Is it a primary type you are expecting or a secondary?
So I was expecting a primary thyrotoxicosis, sir. Since
No,
the hyperthyroidism.
you are not making a diagnosis because this is a tricky condition where there's a 10 years duration. And why you are very particular to say that it is a primary hyperthyroid?
So the history of hyperthyroidism precedes the swelling, sir, and also she is having more of neurological symptoms like excitability or irritability, disturbed sleep, heat intolerance, and tremors. So that's why I thought of primary thyrotoxicosis.
What do you mean by tremor?
Fine tremors were there, sir.
What do you mean by tremor? Then you must qualify, say, and what is fine tremor?
On extending the upper limbs with the
that is for how you are going to examine.
Yes,
no, what do you understand when you say use the term tremor? Because there are so many other conditions can produce.
Yes, sir. There'll be fine tremors, sir, unintentional tremors.
How do you differentiate between cerebellar tremors and tremors of thyrotoxicosis?
So cerebellar tremors will be coarse tremors. They'll be intentional tremors, sir.
So how do you know it is intentional? How do you know it is non-intentional?
Sir, on
How will
putting
you characterize a tremor as a fine or coarse? Is it a physiological tremor or a pathological tremor?
I would
No, you
say it's a
understand fine tremor is never been a complaint of a patient. It is very difficult to understand the fine tremor. That is why you need to do all that. So, I mean, extended investigation to see that.
yes, sir.
It is very rare you get somebody comes with a fine tremor which is presenting in the history. So be careful, especially when you are finding out, when you are committing it as a fine tremor. Fine tremor is something, but it is exaggerated physiological response. It is something like with the adrenaline. You are going to the frequency is more, but the voltage is less.
Yes, sir.
So you could make it out here
On examination, I
for
could
this
make
patient.
out the fine tremor, sir.
How did you make it out?
We put the upper limb in extension, sir, and looked for fine tremors over the hand, sir. We can place a paper over the extended hands.
Paper, postcard. Not a paper.
Okay. Okay.
You don't have any different diagnosis.
No, sir.
What about Hashimoto's disease? How do you exclude that?
Sir, middle age Hashimoto's will probably present with a
If
diffuse
you are
coitus,
thinking
sir.
so long, that means you have not thought about it till now.
It's a
That is not
trifacing
allowed.
disease.
What is the functional status of
You
the
have thought
Hashimoto's
about it and
disease
excluded.
patient?
No.
Yes, sir.
What is the functional status usually of Hashimoto's disease patients?
Hashimoto's disease won't produce
Either-
toxicity. Even if it is produced, it's only a transient. Then very quickly patient goes into hypothyroidism.
Hypothyroid is more likely, isn't it?
Acetotoxicosis. Have you heard?
Toxicity is not. Acetotoxicosis is only transient for a very short
Transient.
time.
So you can
How
rule
will you know whether it is that transient?
Yes, sir.
But during
sir.
What is the relevance of antibody test in the diagnosis?
We'll come to that in the investigation, sir. Let him go
Okay.
on.
Okay.
Yeah, carry on.
Yes, sir. On evaluation, the general investigations were done. Thyroid profile was done, which showed TSH was reduced to 0.005, and T4 was increased. Anti-TPO antibodies were done, which was high, sir. It was 438. Ultrasound neck was done, which showed thyromegaly with multiple nodules in bilateral lobes, thyroids 2 and thyroids 3. Right supraclavicular lymph node of 5 into 6 mm with loss of fatty hilum, and multiple enlarged bilateral lymph nodes were noted, sir, with maintained fatty hilum. USG guided FNAC was done, which showed of the right lobe of thyroid, which was benign, sir, benign follicular nodular disease of thyroid, they mentioned, sir.
What was the importance of the lymph node? Can you go back to the lymph node status? Previous
Yes,
slide.
Yes, sir.
Multiple enlarged bilateral lymph level 1B, 2, 3, 4, 5 lymph nodes.
The thyroid usually drains to the pretracheal group of nodes, sir.
So that is which level?
So level 6, sir.
Level 6.
And
Level 6 were not involved. Enlarged.
after that, it goes to 2, 3, 4, and 5, sir.
Okay. So when would you say these lymph nodes are significant? Like there are multiple lymph nodes, all levels.
These are
So they are significant or not
subcentimetric lymph nodes,
significant?
sir. Yes, sir. These are probably subcentimetric lymph nodes, sir.
Subcentimetric lymph node. Okay, that is one. What are the other criteria on ultrasonogram?
So loss of fatty hilum should be there.
Okay, fatty hilum is maintained. What else?
Did you say the nodules were solid or cystic?
Yes, sir. On ultrasound of thyroid, if it's a solid nodule or if it is taller than wider, if it is hypoechogenic, then it will go towards more towards malignant conditions, sir.
Okay.
Similarly, what are the features
Carry
of
on, carry on.
malignant lymph
Go to the
node?
next slide. Carry on. Next slide.
Till now, this much evaluation has been done for the patient, sir. Till FNAC it has been done, sir.
Okay.
On
What is the sensitivity, specificity of FNAC? What is the sensitivity and specificity of FNAC?
You
not sure, sir.
you suspected thyrotoxicosis, Graves'
Yes, sir.
disease.
Yes,
Are
sir.
you justified in doing FNAC?
No, sir. In hyperthyroid state or in thyrotoxicosis, usually FNAC is not done, or if you want to do, usually USD guided will be done, sir.
You have done.
You have
Yes,
done.
Can you justify that? Why you have done that?
And you say you should not do it.
Like another thing,
Will you get how do you get a nodules in a Graves' disease? Can you get a nodule in a Graves' disease?
So Grave disease will be diffuse enlargement of the.
Question is, can you get a nodule in a Graves' disease? You can.
Yes, sir.
Can.
So what is the mechanism? How you are going to get? And what is the purpose of you doing this FNAC? See, even if you have done something, then you must be able to explain why you are not done. You have a nodule now. What is there is a possibility of tiny malignancy?
Yes, sir. In in cases of solitary nodule, about 12% risk of malignancy is there,
No,
sir.
no, no. 20% is very high. 20% is very high.
We're
Less
talking
than
about
one.
toxic nodule, no?
Less than 1%.
what is this TB-SRTC category? TB-SRTC. What is the full form of this
जैसे
thing?
कोई वार्निंग साइन वगैरह कुछ नहीं था तो ये एकदम
Can you expand this TB-SRTC? Have you heard of the Bethesda system?
Bethesda system, I've heard. Yes,
What is the
sir.
Bethesda system?
It grades according to the grades for suspicion of malignancy, sir. So Bethesda 4 is suspicion of malignancy. Bethesda 5 will be confirmatory for malignancy, sir.
What is Bethesda 1 then? If you get a report of Bethesda 1, category 1, are you happy or worried?
It will be an incomplete or a non-diagnostic, sir. It has to be repeated in such cases.
Yeah, it doesn't mean anything. We're not happy. Okay.
Yes.
And here we notice that they put benign follicular nodular disease. So how reliable is FNAC in categorizing the patient into malignant or benign follicular lesions?
Follicular, this FNAC won't be able to differentiate capsular invasions. So won't be able to see capsular invasions.
Yeah.
So
No, here it has been reported benign. Okay, benign follicular node. So it is excluding malignancy. How, on what basis it can be done? FNAC won't show capsular invasion, as you rightly said, or vascular invasion. So how is it being reported this way?
The cells that they would have examined, sir.
Pardon?
No, I'm not sure, sir.
And go back to the ultrasound report.
Your FNAC, is it shows any features of thyrotoxicosis? Because you are saying that 10 years the patient is on a hyperthyroid. Your diagnosis is also hyperthyroid.
Yes, sir.
What will be the feature of FNAC you will get in a hyperthyroid? What type of follicles? What will be the cells lining the follicles in hyperthyroidism?
The follicles will be hypervascular, sir.
That you can't see in FNAC, no?
They're asking cells.
So normal follicles by the cuboidal epithelium. And what will be the follicles in a...
So Rahul, you finish ultrasound, then we'll go to the next slide. Next, we'll go to the management part of it.
How many nodules did you palpate, Suyash?
No, with the permission of Jailal, sir. Recently in
Yes.
Madurai, one of the endocrinologists spoke about the same thing, and he said the chances of malignancy in hyperthyroid is less than 3%. And that too,
Yes.
when I asked him, how do you diagnose it? Do you have any symptoms particular to malignancy? And he said, no. After removal of the gland, When we send it for histopathology, we get malignancy. So never do an FNAC in a hyperthyroid cell.
Yes,
That's what he
actually,
said.
sir, even 3% is very high, sir. We
No,
found it
no.
less than 1% in our experience.
Now it could be less. Yes, sir, he said it's very less. Only after the histopathology report
We
comes.
never do needle biopsies for thyrotoxicotic MNGs.
Yes, sir.
And if we at all do FNSC, it should be ultrasound guided. Because here also
Preferably,
we have
ultrasound
multiple
guided
nodules
over
here.
the nodule, particular nodule. If you have a thickened nodule
That
or
is
any
okay.
change
That's
in
okay.
opinion, then you can do. Otherwise,
So we
you are
can
not justified
target
in doing.
Okay.
Because already the student has said that he has done the FNAC. That is why we are asking that.
Yeah,
Very good. Carry on to the next slide, please.
Like, yes, what ultrasound characteristics will make a nodule suspicious is that it might be multinodular, but only one nodule might have a malignant transformation. So what on ultrasound, if you're doing guided FNAC, so what features on ultrasound will suggest this nodule might be malignant?
It's more solid than cystic, sir. If it is taller than wider.
No, they are all solid nodules. Okay. How many nodules did you palpate on clinical examination?
On palpation, multiple nodules were there, sir. Palpable on both the right and the left lobe, sir.
Yeah. So if you're doing just a blinded FNAC, that's not of any use. It's not
Yes.
necessarily whole gland will be malignant.
Yes.
So if you're doing ultrasound guided, so what features will guide us to the suspicious nodule?
More of a hypoechogenic, more
What?
hypoechogenic. Hypo, sir.
It's hypoechogenic.
Hypoechogenic.
What else? Hypoechoic is one. What else?
Taller than wider, sir.
Taller than wider. What does that mean?
is-
Taller than wider? What exactly does it mean? See, it has
Uh,
got 3 dimensions: length, width, and breadth. Okay.
Yes, sir.
3 dimension nodule. So what do you mean when you say it is taller than wider? Which dimension is tall? Which dimension is wide?
I'm not sure, sir.
Hmm?
I'm not sure, sir.
Okay. Any other feature?
Extrathyroid
Guide?
extension is there, sir. If any
Pardon?
extrathyroid extension is there.
Okay.
And microcalcification, sir. If calcifications are present, microcalcification.
Microcalcification. What else?
More vascularity, sir.
So we can combine a Doppler ultrasound. Okay.
यही व्हाइट शर्ट है ना, उसकी यहाँ से थोड़ी सी जेब खुल रही है. चलो आराम से करो, कोई वो नहीं. मेरे को वही डर था, कहीं वो हो गया तो फिर इसकी वहां ले जाना पड़ेगा.
Yes, sir, please.
Okay, go ahead. Go back to the slide. Last slide.
This is the last slide I have, sir. Till now,
Okay.
on management aspect, we have done till FNA, sir.
So how will you prepare this patient for surgery now? We need to prepare him for treatment.
Yes.
So how will you prepare him for surgery?
Patient is in hyperthyroid state, sir. We will give him beta blockers, propranolol. Usually about 40 milligrams per day is given. Can increase till 80 milligrams per day. Carbimazole or antithyroid medication is given, sir.
Any other medication we might give?
Do you give Lugol's iodine?
Lugol's iodine? What is the role of Lugol's iodine?
Yes, sir. Lugol's iodine can also be given, sir.
How does it help out? Lugol's iodine?
It decreases the vascularity of the gland, sir.
It decreases the vascularity of the gland. Okay.
It makes the gland firm. Then what else does it do?
Makes the gland firm. Otherwise, these toxic glands are very soft. You try to mobilize them.
What is the other action of iodine?
So the conversion.
It releases the globulin from the acini, so it blocks the release. So it produces any subclinical toxicity, it will control.
Thyroid constipation.
Of course, there are people who don't use it, but in examination, you say that it is useful because most of the surgeons use it.
Okay. Here I noticed that you've not, like you've done all the investigation, but you've not commented on the ECG. Neither have you done an indirect laryngoscopy. So are they not important in this patient, electrocardiogram and the indirect laryngoscopy examination?
They're important, sir. ECG will look for ECG to rule out fibrillation, atrial fibrillation, sir.
What? Atrial fibrillation is the extreme part. What are the other changes that you look for in
Sinus tachycardia will be there, sir.
any other? What about indirect laryngoscopy?
Indirect laryngoscopy is necessary, sir, before surgery, mainly for medical legal purposes to look for the movement of the vocal cords, sir, bilateral movement of the vocal cords.
If the voice is normal, should we still
Yes.
do indirect laryngoscopy or not?
Yes, sir.
Why?
In a small percentage.
Ayush, what is the patient's pulse rate?
So it was about 80 beats per minute, sir.
Why do you want to give propranolol? No, just
Yes,
to know what you are thinking. So does it have role in anything else other than just controlling the tachycardia? Yes, definite indication is tachycardia. Your patient is maybe under control, but what
also,
else?
Yes. The peripheral conversion of
Yes, inactive T4 to T3. This is one of the important things it does. Controls the tachycardia fast. Kyle's grading of the toxicosis. Do you know Kyle's grading? Kyle's grading. See, all this sleeping pulse rate and all is now not really being done. Radio, the so-called what you can call as the iodine intake. Also, all these patients who are prepared Lugol's iodine probably is not even available. We don't do it, but anyway. So tell me, what is Kyle's grading at a clinical? So 90 to 100, 100 to 110, 110 to 120. So that's how you say it. Severe tachycardia beyond it, 120, 130. So what is the eye sign she's having other than this? I saw a little bit of prominent eyes actually. One side.
I could see lid retraction, sir. Other than that,
slightly. Anyway, these are symptom overlap can happen in primary and secondary. There is an overlap in your patient. So this is what we are trying. And this, so the leg edema you mentioned, no? Leg edema.
Yes, bilateral pedal edema is there, sir.
What was the explanation for that?
So I thought it was because of patient maybe in congestive cardiac failure, sir.
So did you mention anything about the liver palpable, etc., JVP, etc., so important in your patient? So important, or whether she has gone for hypothyroid, bilateral pedal edema, like myxedema features, so it doesn't look like. So what I'm trying to tell is this is all very, very important from the management point of view. She's in a congestive cardiac failure or cardiac reserves. I already mentioned to you the importance of this examination. So this question I asked because especially propranolol, this issue has come. Okay, yeah, that's all. So please continue.
Also, propranolol, another role of propranolol is to, like, patient is almost doesn't have tachycardia, normal pulse rate almost, but intraoperatively he might still be susceptible to a thyroid storm. Okay.
Yes.
So if we put him on propranolol beforehand, so there are less chances that he'll have intraoperative tachycardia. So that will also be reduced.
The same reason we give
also,
iodine.
you've not done a X-ray of the neck. AP and lateral X-ray of the neck is very important. Then you've not checked the reflexes also, whether hyperreflexia or what sort of myopathy do they develop? You didn't check about the myopathy. They develop myopathy also. What these patients?
Proximal neuropathy, proximal myopathy they'll develop, sir.
So did you check for that? How do you check for proximal myopathy?
We'll ask the patient to sit up, sir, from a stand up from a sitting position or
not sitting, squatting.
So you should have done that also. If she's an elderly woman, so she might have proximal myopathy. Okay.
Yes, sir.
So that also you missed. Okay.
Yeah.
Reflexes is very important in this patient. All these things you.
Yeah, they develop something like a myasthenia-like symptoms sometimes.
Yes.
Okay.
What's the Eaton-Lambert syndrome?
Next slide. Go to the next slide.
Eaton-Lambert syndrome. Have you heard of that?
Let us talk about the management.
Okay, talk about the tell us about the management.
Sir, since TSH is low, patient nuclear scan can be done, sir. Nuclear scan can be done. If there's a hot nodule or a cold nodule to look for, sir. If there's a cold nodule, patient can be taken for ultrasound, and then FNA can be done, sir.
You already done ultrasound FNAC. Now you are going to
Yes.
do again.
You are doing already.
sir.
We said it should not be done. You want to do it again. Don't keep on doing needle biopsies.
Yes.
One biopsy is
No,
enough.
the next step in this patient will be to control her, make her euthyroid, and then plan for surgery, sir.
Are you sure it is not transient hyperthyroidism?
So she's been telling that these symptoms have been persistent since the last 10 years, sir.
So then they might have used the same drug, carbimazole and Inderal. Probably
Yes.
the drugs are not effective. Do you have any alternative?
Propylthiouracil can be taken.
But
They are
you
same.
said that
Probably the
swelling
same
was
method is
for
also
8 years. How symptoms started early?
Sir, the hyperthyroid symptoms have been there since 10 years, sir. And the swelling was first noted 8 years back.
So did she take any treatment for those 2 years?
Yes, no, she was started on medication about 7 years back, and in between for 3 years, she was non-compliant with the medication, sir.
Sure, you believe that thyrotoxicosis present for 2 years without any swelling. Then after 2 years, swelling started.
Yes, sir.
That is a history you are giving, and you are believing that history. It is possible, no? You believe it is possible? It takes 2 years for swelling to appear, but before that, you have a thyrotoxic features.
So probably the swelling was not noticed by
Something
the
wrong in your
patient.
history
or the
taking.
patient
You have
file.
not taken the history properly. You have not spent time with her and discussed what it is exactly happened and where she has made a mistake. And now the nodule is formed, when it is formed. All that history you should have brought in. Can you get an eye sign in a secondary thyrotoxicosis?
Yes, so usually eye signs will be there in secondary thyrotoxicosis, sir.
Usually, eye signs will be there in secondary thyrotoxicosis. Eye signs are features of the primary thyrotoxicosis.
Primary, sorry, sir.
What
Yes.
eye sign will be present in the secondary thyrotoxicosis? So your lid lag and lid retraction can present in the, because
Lid
that's
lag, yes.
all due to the increased thyroid, the secretion of the more sympathetic activity.
Yes.
The other eye signs, exophthalmos, is nothing to do with your sympathetic activity.
Yes.
So this
Where
can
do
present
cardiac features predominate and where do neurological features predominate? In which varieties?
In primary, neurological will be more predominant, sir. In secondary, cardiac features will be more dominant, sir.
Secondary. How do, on the basis of thyroid function test, how do you differentiate between primary and secondary variety?
Not sure. We can look for free T3, T4, sir.
T3, T4,
It
or on
will
the
be,
basis of
it will be
TSH?
the same in both. Don't get
TSH will
confused.
be TSH will be on the lower side, sir, in case of hyperthyroidism.
No, primary or secondary. The TSH will be
No, it will be the
diametrically
same.
opposite. What is the
Profile
difference?
will be the
Yes,
same. Don't get confused. In both, it will be the same.
but you can do antibody test to differentiate
Yes,
whether
sir.
it is a Hashimoto's Hashimotoxicosis
Yes.
or in a
Uh,
peroxidase antibody will be more positive in Hashimoto's.
yes, sir. TP antibodies will be there in.
Similarly, we have transient hyperthyroidism could be exogenous thyrotoxicosis. You are giving somebody taking the, then that is the
medication.
only way to differentiate is measuring the thyroglobulin assay.
Yes.
So here it is, you have a 2 antibody test to differentiate, but with the exogenous, then you have to see the thyroglobulin. It will not increase in an exogenous thyrotoxicosis.
Okay, sir. Yes.
So now, what is your plan? You have seen, you have done an FNAC. It is comes as according to you, it is a benign.
Yes, sir. First, we will make the patient euthyroid, and then
How long you will wait?
usually we'll follow up the patient every with the regular thyroid function tests, sir, every monthly or 3 monthly.
Why you don't have any alternate treatment? See, with anti-thyroid drugs, she is not becoming euthyroid. So
Yes, sir.
you should think of some alternate treatment, no? Is there any alternate treatment you know?
Radioiodine therapy, sir.
Why don't you consider? What is the problem?
Yes.
Why you want to keep on waiting till she develops arrhythmias and other complications?
Yes.
Huh?
Yes, sir.
You should have thought about it, sir. She's not fit for surgery because she wouldn't make it. You couldn't make it euthyroid.
Yes, sir.
Consider iodine therapy.
Yes, sir.
Hmm?
Yes, sir.
This is the best course. The best treatment will be for her will be radioiodine therapy, no?
Yes, sir.
How much dose is given? Radioiodine. Approximately 1 millicurie per 1 gram, estimated 1 gram weight of thyroid. So roughly 25 to 30, 40 millicuries.
Okay.
Approximately.
Okay, sir.
Okay.
Yes, sir.
So you know the how they are doing the test. Thyroid ablation, how it is being done, and what is used, and what is the dose. Sarah has now explained the dose for you.
Yes, sir.
How do you measure the gram? How much gram? Okay, go.
Suyash, do you think this patient would be at great risk for tracheomalacia? Do you
Yes,
think
sir.
it's likely she's thyrotoxic and large nodule for 10 years now?
Yes, sir.
So is there any, you think she's at high risk for tracheomalacia or not?
She is at a high risk of tracheomalacia, sir.
So did you do any clinical test to check for that?
Cockers
No, you
test.
didn't mention that. You were waiting to hear that.
But don't do that.
Test.
We advise you not to do the Coker's test because sometimes you may produce irreversible tracheal obstruction and
Any
get
other
into an
test that you can
emergency. So don't do Coker's.
Scabbard trachea.
Any test that you can do for other than that Cockers test, any other test that you can do?
Usually Strider will be noted, sir, if tracheomalacia is there.
What is?
Not sure, sir.
So what are the problems she's likely to have intraoperatively? What surgery will you do if you plan for surgery? What is the recommended surgery?
So total thyroidectomy, sir.
Total thyroidectomy.
Yes, sir.
Now suppose
intraoperatively there'll be a risk of thyroid storm, sir.
Yeah. Now suppose you're doing total thyroidectomy and you mobilize. It's more on the left side, isn't it? And on the left side you're mobilizing, and you're not able to visualize the laryngeal nerves. Okay, recurrent laryngeal nerve or supralaryngeal nerve.
Yes.
So how can you change your treatment plan then? You are trying to identify where the recurrent laryngeal nerve is, RLN and SLN is there. On the left side where the bulk of the disease is there.
Yes, sir.
You mobilize it.
We can go ahead with subtotal thyroidectomy, sir.
What is that procedure called?
Dunhill's procedure, sir. Dunhill's procedure in which one.
So what is that? That's not exactly subtotal. What is it?
It is
called a near total.
one
It's called near total.
lobectomy with unilateral lobectomy with isthemectomy and subtotal.
Yes, on the involved side, it is total lobectomy. Okay.
Yes,
and on the less involved side, we might leave a sliver of tissue. Okay.
Yes, yes.
Sure, sir. You set of thyroid storm. Can you get a thyroid storm without surgery?
Yes, sir. In case of acute stress or
don't get too much of worry about thyroid storm.
Okay, sir.
That is not a big problem for you to think always, because thyroid storm can come even when you're not operating, when you are handling, or in an infection setting.
Yes, sir. Yes, sir.
That's not an absolute. I mean, dare to say that I will not take the case for surgery.
Yes.
Okay, let us just go to one another subject. Suppose the FNSC showed suspicion of follicular carcinoma. What will you do now?
We'll make the patient euthyroid and then.
Pardon?
So we'll do imaging, sir. We'll do a CCT neck to look for lymph nodes, metastasis or lymph node involvement.
Okay.
If any
Sir
Does
said
it go-
follicular carcinoma. You are going to get a lymph node in follicular
You-
carcinoma.
Does it go to lymph nodes or does it go to somewhere else?
So hematogenous spreads are more of.
So
in
what
case
is the best investigation?
Mm.
Either I-131 scan or a PET scan.
PET scans, sir.
Yeah, one of the two. Whichever is available, whichever the patient can afford.
Yes.
Hmm?
Yes, sir.
Okay.
And then once the patient is in euthyroid state, we can plan for total thyroidectomy, sir.
So you will wait for euthyroid once you are knowing it is a carcinoma.
I'm not sure.
That is
sir.
a teaching. Oh, okay.
Okay, you have done total thyroidectomy. It is follicular carcinoma confirmed. What
Yes.
next?
We'll go ahead with the total thyroidectomy. Either a iodine 131 scan or a PET scan, sir. Look for metastasis.
Oh, you
Why-
look for
why
it.
do you
You
want to
already
do
done
PET?
pre-op. Why you want to do again post-op?
Sorry,
Keep
sir.
on doing PET scan.
I didn't get the question, sir. Sorry, sir.
Question is, after surgery, what will you do?
Okay, sir. After
How
surgery,
will you follow up the case in patient?
Yes.
iodine 131 ablation can be done, sir. Radio
Can be done is not the question. Will you do it or not?
What
Anything
you
can
will,
be done.
be
what
done, sir.
you will
Will
do?
be
Why
done,
do
sir.
why do you say it can be done?
Yes, sir. Will
As
be
if
done, sir.
as if you are giving the option to me.
Yes,
Is
sir.
You
there is any
don't-
role of thyroglobulin assay?
Thyroglobulin is a surveillance for surveillance. Do you put the patient on thyroxine?
Yes, the patient will be started on thyroxine, but first,
Everything we have to ask you questions, no?
What
So
what is the dose you will
what
give?
is it you do after surgery? So
What is the dose of thyroxine you will give?
follicular carcinoma.
We give a suppressive dose or supplementary dose?
we'll give a suppressive dose, ma'am.
No. Suppressive dose in
What will be the
papillary.
dose?
Sorry, we'll
Here it is only replacement.
okay,
0.1.
0.1.
There it is 0.3. Okay.
Yes, sir.
Both
further, how will we follow up
both
the patient?
differentiated tumors, papillary and follicular, post-op radioiodine therapy is a mandatory now.
Yes. Yes.
Because micrometastasis you can never identify by any scans. So that will take care of. Only for differentiated tumors,
Yes.
not for medullary or anaplastic.
Yes.
Okay, last
You-
question.
you
Suppose
are-
the
you are
FNAC,
doing
Jailal.
You are doing isotope scan in the post-operative period. Your thyroglobulin value is increased, but
Increase.
isotope says no node, no secondaries.
Yes, sir.
You have done a radioaptec scan, nowhere it is taking up,
Yes, sir.
but your thyroglobulin value is increasing. That means that is functioning.
There's a residual.
Residual means it will take it up, no?
Yes, sir.
Do you have any condition known by that? Thyroglobulin elevated but node negative. So that it is indicated is a PET scan, where there is the tumors cannot take it up because of the sodium iodine importer mechanism is failed. So that time PET is indicated, especially when you have a thyroglobulin value is increasing and your nodes are not being picking up by the secondaries. Suppose the node is taking up this, we call this a hot nodule or a cold nodule. Suppose your bone is taking up, so you call it as a hot nodule or a cold nodule.
So cold nodule is usually malignant. So cold nodule.
No, that in this condition, post-operatively, there is a nodule is picking up. We call it as a cold or hot.
Anything that is picking up isotope is a hot nodule, doctor.
Yes.
In the thyroid, in comparison with the rest of the thyroid, you are going to say
It's
it's
cold
cold.
because it's in comparison to the rest of the gland. It is cold, but here compared to the remaining skull bones,
yes, sir.
It is hot.
Always hot.
Okay, last question. Suppose the FNAC is suggestive of medullary carcinoma. what will you do?
Sir, along with thyroidectomy, neck dissection will also be required.
Pardon?
Along with the thyroidectomy, neck dissection will also be required.
Wait. No. Don't be in a hurry. You don't want to look for other endocrine tumors. You don't want to do tumor markers. What is it? Why are you in a hurry to do surgery?
Yes, sir.
You must evaluate the patient properly. Suppose he has a pheochromocytoma and you operate, what will happen? You lose him on the table.
Yes, sir. Yes, sir.
See, the question is there. There is a question. There must be some reason why I asked that question.
Yes, sir.
Don't jump to surgery immediately.
Further, we'll look for features of meant to A or meant to be syndrome, sir.
Correct. That is one thing. You must
Look at oral.
you must also screen the first degree relatives.
Yes, sir.
Then
Yes,
you
sir.
must do the tumor marker level for surveillance, post-op surveillance.
Yes, sir. The calcitonin levels we'll look
So
for.
you must do all these things before you do surgery, no?
Yes, sir. Yes, sir.
Don't jump for surgery immediately. This is a small trap. We lay a trap for you and you fall into the trap.
Yes.
Always preoperative evaluation is very important. First staging, then
Yes,
surveillance, everything is important.
yes, sir.
What lymph node dissection you do for medullary? You do any lymph node dissection?
Central neck dissection.
Level 6.
Level 6.
Is it a prophylactic or therapeutic? You do prophylactically, or you will do only when it is node is palpable?
No, sir. Prophylactically it will be done, sir.
In the papillary carcinoma?
In papillary carcinoma, it is prophylactic, sir, because it has more of a lymph nodal spread, sir. Lymphatic spread.
No. In the medullary carcinoma, you do prophylactic central neck dissection.
Yes,
In a papillary carcinoma, only when it is crossing T3, T4 lesion, you are justified in doing a prophylactic neck dissection. Otherwise, you are not doing. But in here, it is mandatory you are going to do.
How do you identify post-operative hypocalcemia, hypoparathyroidism?
we look for calcium levels, sir.
How do you look
You
for?
are in the ward rounds. In the ward round,
how do you look for? What symptoms patient will have, and then what signs you elicit?
How the patient will present. Post-operatively, how the patient will present. Immediate post-operative period after total thyroidectomy.
What is the early symptoms he develops?
Not sure. Very.
Yeah. Okay.
So perioral numbness.
Yes, sir.
Perioral numbness. That is the earliest thing he develops.
Yes.
And then sometimes he may develop twitching also.
So
then how do you confirm? What clinical test you do? What is Chostek sign?
On tapping the masseter, on tapping the cheeks,
what tapping on what? On what nerve? What is the nerve there in the face? There is only one nerve there.
Facial nerve, sir. On tapping the facial.
Why you are not thinking about it? There is only one nerve there.
Yes.
And what happens when you tap on that?
The muscle will go into contraction, sir.
There will be twitching of the.
Twitching of the.
Twitching of
the area supplied by
twitching of the facial muscles.
Yes.
Okay.
On tapping
any other
facial
test?
nerve.
What is Trausch's sign? Put a BP cuff, inflate it above the systolic.
Yes, sir. Yes, sir.
And we go into carpopedal spasm.
Carpopedal spasm, yes, sir.
Okay. Now, what is the most dangerous dangerous symptom patient may develop, which requires emergency treatment?
Post-operatively, sir.
He may go into laryngeal spasm. He may go into laryngeal spasm.
Yes,
you have to be very careful about that.
Yes, sir.
You must look
Will you
out for that.
confirm he has hypocalcemia?
Sorry, sir.
How do you confirm that he is having a hypocalcemia, and what hypocalcemia, at what level you will start treatment?
We'll look for calcium levels, sir.
Which calcium you require? Total
Sir,
calcium, elemental iron.
corrected calcium levels, sir.
Illa. Doctor, calcium levels most of the time is normal. You simply go by symptoms. Calcium level most of the time it will be normal.
Okay, sir.
Because it's so sensitive, and even small variation can produce symptoms much
Yes.
before the biochemistry can pick up.
So suppose the patient
Calcium is only for
hyperventilating.
documentation, but don't wait for the calcium to come down. The patient has symptoms, you treat. Start treatment.
Yes.
Suppose the patient is hyperventilating. Okay,
Yes, sir.
she
Yes,
is
sir.
tachypneic. Okay, so
Yes,
can
sir.
that precipitate symptoms of topopedal spasm or Chevostek's time?
Yes, sir.
See, after the operation,
Suppose-
patient is tachypneic. Okay, she's got a respiratory rate of 40 per minute.
Yes, sir.
So can that precipitate some symptoms?
Hyperventilation, sir. There'll be CO2 washout.
So what will happen? If CO2 is washed out, what
Yes, sir.
electrolyte imbalance occurs then?
Hypocalcemia can occur, sir.
No, it leads to respiratory alkalosis.
Yes, sir.
So if there is alkalosis, then even with normal calcium level, the symptoms can manifest. So suppose if you want to calculate the corrected serum calcium, so what additional information do you need besides the normal besides the serum calcium level? What are the value you require?
Albumin levels are needed, sir.
Albumin level.
Serum proteins.
What is hungry
And
bone
how much is-
hypocalcemia? What will happen to the phosphate level when the calcium is low?
It will increase, sir.
You must know there is a spurious hypocalcemia, hungry bone hypocalcemia, fixational hypocalcememia. So what values to be adjusted? Because most of the time the ward rounds, these will be the questions will be asked, because most the questions will be on electrolyte balance. So hypocalcemia, when you are going to start, and what is the complication you get when you transfuse calcium gluconate?
If the patient is on digoxin.
How will you treat the hypocalcemic tetany? Suresh,
Sorry, sir.
how will you treat hypocalcemic tetany? How will you treat hypocalcemic tetany? How will you treat tetany?
We'll give calcium gluconate, sir.
Develop hypocalcemia in what? How will you manage?
We'll give calcium supplement. We'll give calcium gluconate, sir.
Doctor, the answer must be, depends on the severity of the symptoms. You can give oral, you can give IM, you can give IV, depending upon the severity of the symptoms. That is the correct answer.
Okay, sir.
You understand?
Yes,
And
sir.
then maintain orally, if necessary, for indefinite period of time, till the symptoms subside.
Okay, sir.
How much is the ionic calcium fraction normally?
Sorry,
Suppose
sir.
the serum calcium level is 9.4. What would be the normal ionic fraction of that? Then
Ionic calcium, 50%.
in which test do you
How
get
much
the ionic
percentage
calcium
of the
level?
calcium is ionized? Sir is asking.
In which test do we usually do routinely? Which shows the ionic calcium level? What is that test?
I'm sure, sir.
It's arterial blood
patient-
gas. Arterial blood gas gives you ionic fraction, isn't it?
Patient requires a long-term calcium therapy. You can even consider giving a parathormone also.
Okay, sir.
Okay.
Okay, sir.
Not immediately. If it requires long-term.
Yes, sir.
Okay. Now, what are the various causes of upper airway obstruction following thyroid surgery?
So in immediate post-op period, they can develop a hematoma, which can cause
Okay, very
total
good. Number one. Number two.
There will be nerve palsy, sir. Either
Professor Khanna already mentioned one condition.
Tracheomalacia.
Tracheomalacia is the second one.
Tracheomalacia,
Then
especially
third
after
one.
large thyroid.
Third one.
Laryngeal nerve palsy, sir.
Sacral nerve palsy. I think these are
Sacral
the
nerve.
3 important reasons for upper airway obstruction.
Yes.
So suppose you finish the surgery and at the time of immediately after extubation, there is a patient has respiratory obstruction. Then what should be done?
Tracheostomy should be done, sir, at that time.
No.
What do you suspect at that time?
Don't do
Immediately after
tracheostomy.
Either laryngeal edema will suspect, sir.
Laryngeal
To
edema is
be
one.
kept
What are the
on,
other?
should not be extubated, sir.
No,
Intubation.
that is one thing only. That is
You already
that is
extubated. Extubated, there is a
Right.
stridor.
Yes, sir.
What are the other things that you
Reintubation.
suspect? That
Reintubate.
the only thing.
Reintubate. Don't do tracheostomy immediately. Reintubate.
Reintubate, yes.
No,
Sometimes
is that the only thing? Laryngeal edema. There are other things also, isn't it?
Yes, sir. Yes, sir.
It might be a tracheomalacic thoracic trachea that is collapsed, or it can be bilateral recurrent laryngeal nerve palsy, isn't it?
Correct.
Yes, sir. Yes,
All 3 can be there, not just one. So how do you differentiate between the 3 varieties? Immediately, like surgery is finished, extubation
laryngeal
is done.
edema will usually settle down, sir. And
What?
Laryngeal edema will settle down in post-operative period.
No,
and
at that time
after
you
that,
got to
video laryngoscopy should be done to look for
laryngoscopy. First, you see the vocal cords, whether they're moving or not. Okay.
yes, sir.
Second, what else? And suppose you've extubated and patient is not able to breathe, and laryngoscope and as it is not able to pass the endotracheal tube, what can be done?
In that case, tracheostomy will be required, sir.
Before that, any other step we can do before that? Video laryngoscopy can be attempted under vision, isn't it? Have you seen that?
Yes, sir. Yes, sir.
Video fiber optic laryngoscopy.
Yes, sir.
And any other thing? Guide wire, anesthetic can pass the guide wire, then over that trachea.
Yes, sir.
This thing has been said,
Yes, sir.
endotracheal tube.
Percutaneous
last
tracheostomy. Percutaneous
not the first
wire-guided
option.
tracheostomy.
Yes.
So how will you do the tracheostomy?
Look for the thyroid cartilage, sir.
What
So you are
cartilage?
going to open the thyroid cartilage.
No, sir.
What cartilage?
What? Open the thyroid cartilage?
No, sir.
Yeah.
Cricothyroid, we'll look for the
Okay. Have you done
there
the tracheostomy or have you
emergency
seen?
in cases of emergency tracheostomy? Cricothyroid ligament will be.
No, the tracheal rings are in front of us,
How do
isn't it?
How do you fix
Trachea
the
is closed in
trachea
front.
before
Sorry,
incising?
sir?
How do you fix the trachea? Sometimes it slips away, no?
Yes, sir.
How do you fix it?
While doing tracheostomy, we'll take stay
It's called a
sutures. sir.
tracheal hook that fixes to the cricoid.
Okay, sir.
Then you do the opening of the trachea. Otherwise, it will slip. It will disappear.
Yes.
Hmm?
Yes, sir.
So we are talking so much about hypocalcemia. What could be the cause for this?
Parathyroid or
So how do you know in the post-operative period, on the immediate after surgery, whether you have removed the parathyroid or not?
vasos? Not sure, sir.
You can see the specimen. Suppose you see
sir.
that all the 4 parathyroids are out.
You should take a strong decision not to do thyroidectomy hereafter.
How do you identify the parathyroid gland intraoperatively during the surgery? How do you know it's not a cervical lymph node, it's a parathyroid gland or not an adenoma?
The fatty consistency, yellow in color, sir.
Okay. Yellow in
It's
color.
very difficult. When there is a bleeding, it's very difficult to see it is a yellow in color.
Be around the posterior
That's
aspect.
fine. or the blush sign, easy bruisability. When you're mobilizing tissue all around that, it will start turning red, the parathyroid gland. So that's the blush sign. Okay.
Okay, sir.
Otherwise, can you do a intraoperative PTH level during the surgery if you are in doubt
Yes,
after
sir.
the specimen has been removed? What is IPTH? IPTH. IPTH. What is
Yes,
that?
sir.
What is that?
Not sure, sir.
Intact parathormone. Intact parathormone. So we can do it intraoperatively. Why? What's the concept behind that? During the surgery,
There's
we
a,
can do the IPTH level as soon as we remove the specimen. What's the concept for that? Behind that?
there'll be a sudden decrease in the
No. Why can we do it intraoperatively only, the IPTH level? What's the basis for this test? It's a short half-life. PTH has got a half-life of only 3 minutes. Okay.
Okay, sir.
So as soon as we remove it, within 3 minutes, the IPTH will fall, serum PTH level.
Okay,
That's why we
doctor,
can do it
before we
intraoperatively.
go, how do you treat anaplastic carcinoma? FNAC is suggestive of anaplastic carcinoma.
Yes, sir. See, if it's inoperable, sir, the tracheostomy will do,
Again,
sir.
you are going to the operation immediately, doctor. Once you made a mistake, I corrected you. You are again doing the same mistake within 10 minutes. You are hopeless. You don't evaluate the patient. You don't know whether he has secondaries or not.
Yes, sir. We look for the.
So straight away you go and do surgery.
No, sir.
What is this? You're a PG student. Once I corrected.
Yes, sir.
Making the same mistake again.
Yes, sir.
Moreover, it's a very rapidly spreading tumor. It goes in all modalities. You see
Yes.
what stage, what lymph nodes, lungs, bones, everywhere.
Yes.
Doing tracheostomy is only if there is any airway obstruction. Otherwise, what is the emergency doing tracheostomy?
Yes,
But what is the definitive treatment?
Definitive treatment.
Surgery usually useless unless it is very early stage. Most of the time, no surgery or surgery, they live the same time, same period.
Yes.
So best is to avoid surgery. That
Yes.
is general. Most of the seniors feel. You can go for other forms of treatment, radiation and chemo. Surgery can be done. If it is easily movable and early stage, maybe you can do it. But
Yes.
most of the time, they come very advanced.
Yes.
And surgery becomes very difficult and very risky also.
Yes.
Best is to go for other forms of treatment.
Yes.
And tracheostomy or hysterosectomy to separate the both lobes, so there will be no compressing effect on the trachea. That can be done.
Yes, sir.
Okay.
Yes, sir.
What's the Siemens law? Siemens law regarding the damage of injury.
Not sure, sir.
Which
Siemens
part
law.
of the nerve will be damaged first? Adductor and abductor, no? Which sectors will go first?
The adductor compartment, sir.
Siemens law.
Which muscle does the superior engine now supply? External branch of the superior engine now?
Picothyroid, sir. It's a tensor.
What is the function of that muscle?
So adductor, it's a tensor of vocal cord, sir.
Sure. RLN supplies the adductors or the abductors of the vocal cord?
Both.
It supplies both, sir. Adductors as well the abductors.
Okay. So if the recurrent legend nerve is injured, which function is lost first? The adduction muscles go first or the adduction?
I think adduction, sir. The adduction function will be lost first, sir.
No, it's the abductor.
No, the other way around.
Abductor function goes first.
That's
Okay.
the way they go into stridor.
So
The
vocal cords can
adductors are
become
working
paramedial.
unopposed, so they go into stridor.
What about this thing?
Siemens law is genetically whichever group of muscles develop earlier,
Yes, sir.
they will stay longer. Whichever group developed little later, they are affected first. That is the Simmons law.
There's a second component in this law also.
Yeah.
Like, which is more dangerous, partial injury to the recurrent angina or total transection of the recurrent angina?
The question
That
is
is second
simple.
component.
You answer. If you
Yes,
are
sir. If there's partial injury, so the abduction will be lost, and then that will create more stride. Only the adduction will be working, sir. The adduction function will be working, and that will create more stridor, sir.
Partial injury is more dangerous.
Airway compromise. Yes.
If partial injury is there, the muscles, the cords are going to be paramedial. While if there is total injury, total transection, then they will assume a cadaveric position.
Yes, sir.
So cadaveric is not paramedial.
Yes,
So
sir.
cadaveric is abducted. Okay.
Yes, sir.
So that when that the voice will go totally, patient will have risk of aspiration.
Yes, sir.
But the patient won't have respiratory obstruction, although
Yes,
there will be a great chance of aspiration.
Yes.
But if there is a partial injury, then patient can have respiratory obstruction because the
Yes.
vocal cords will be in the paramedial position.
Yes, sir.
So that's the second component of the Siemens law.
Okay, sir.
What is the peculiarity of the carcinoma thyroid in contrast to all other cancers? There is something very peculiar. Very important to know that most of the other cancers, the older the age, better the prognosis. Whereas here, the younger the age, better the prognosis. Totally different from all other cancers. Because anaplastic tumors occur in the older age, differentiated tumors occur in the young age.
Yes.
Yes. Okay.
Yes.
Any other questions, sir? Shall we wind up?
Yes, I think we can wind up.
I think, sir, you must be extremely fortunate today to get the questions from Professor C.M.K. Reddy, sir. He's such a octogenarian surgeon.
Thyroid
We all
is
are his students, and we have.
Nice to see you.
Thyroid is my favorite subject.
Okay, sir.
And
you
are most fortunate PG.
It's a hard subject for the PGs also.
Yes.
Thyroid. They don't allow any mistakes because it's a common disease, no?
Yeah.
Yes. Yes.
It's all mathematics in thyroid, sir.
Yeah.
Thyroid and
thank you, Dr.
hernia.
Rahul. I think your participation was very useful.
Thank you, sir. Thank you so much.
Narendra Gupta, good night. Kanagavel. Hey, Kanagavel, நீங்க பேசவே இல்ல.
Sir, when seniors are speaking, I listen.
Okay. Well done, Suyesh. You have done very well.
Okay, Suyesh. All the best to you for your future career.
Sir, one moment, sir. Dr. Suyesh, do you have any doubts to get clarified with all the
If you have any doubts, you can ask us.
Suyesh? I think he has some challenges with it.
I have one doubt. What is the normal position of trachea?
Sorry, sir, what is the?
Normal position of the trachea.
Okay. It is little shifted towards the left of midline. Am I right, sir?
No.
Is that question directed to the location or what is that you
normal
want?
position? What is the normal position of trachea when you palpate above the sternum? It is slightly to the right. You know why?
Okay.
You know why? Because the entire carina is pushed to the right by the aortic arch.
Okay.
That's why it is slightly to the right.
Okay. Embryologically. Yes, sir.
Okay.
Yeah. Thank you, sir.
Thank you, sir.
So yes, if you are having any questions, please ask us. When the
Do you have any question? Ask her. You ask the presenter can ask any question.
No, sir.
Thank you.
Really fortunate to have
so yes, you please note down the areas.
I know what is your question. Your question is, when are you going to leave me?
So yes, you please note down the areas where the faculty are pointing out the important things, no?
Yeah.
So it is always important to learn and improve ourselves. Go back to the library, sit on the areas where you find little bit weak, and then there are always learning is a continuous process. Go back to the library.
Yes.
Always make sure you teach your CRRIs and juniors on rounds. We
Yes,
allow
sir.
them to ask questions. That's how we improve upon. That is one other important thing we'd like to do. And
Yes,
thank you for joining this. Give
Good
my
night, sir.
kind respects
Good
to
night.
Dr. Abhishek sir as well as Dr.
Thank you,
Sriram
Jalal.
Bhatt sir.
Thank you. Okay.
Yes,
Yes.
sir, please. Sir.
Thank you.
Thank you.
Thank you,
Thank you.
sir. And with the permission of the faculty, and thanks for joining all of you. Next week will be a case of parotid, but then there is some other added information from the parotid gland, and other information we will keep you informed. I thank the invited faculty, Gupta sir. Gupta sir is a cardiovascular surgeon himself, and he right now is in Sitapur heading the Department of Surgery. Thanks, Dr. Nishikant sir, for introducing us, Dr. Gupta. Gupta hails from like he did his MCH from Tamil Nadu only. It looks CMC Vellore, and we had a good chat earlier. Very happy to have sir. And thank you, Babita ma'am. Thank you, Rahul sir and Jailal sir. Thank you for joining us. Kanna sir, any other comments, sir? Ajay sir, Ajay Kanna sir. We have two Kannas.
Yes, thank you. Dr. Ethan is joining.
Yeah, I think one of the most important debate in this presentation was the role of the FNAC in this patient,
Yes,
which
sir.
Dr. Jailar pointed out. And I do agree that this patient did not require the FNAC.
Yes.
It is not going to give any information in this patient. And
Yes.
it is associated with the complications. You know, if you do FNAC in a thyroid, hyperactive thyroid, there's a very high chance of having the hematoma and the hemorrhage is there. And even the patient can go, like in the patient in the radiology department, you find that the patient goes into thyroid storm after the FNAC. So probably this was not required in this patient because it is not going to add to anything. In a patient who is a hyperthyroid patient with a multinodular goiter, until unless there is a very specific nodule which is there, which is very big nodule which is there, you can go for that, but otherwise it is not required in this patient.
Yes.
Second thing is about the X-ray of the neck has to be done. You know, this probably you missed that. X-ray of the neck, both AP and the lateral view has to be done. And this is helpful both for the surgeon as well as for the anesthetist. Anesthetist will know that in which direction the trachea is there. And he will also know that what size of the endotracheal tube he is going to use there. And the lateral view, which is important from the surgeon's point of view in the sense that is this patient is going to lead into the tracheal compression or not after that. The patient can go into the tracheomalacia, means there will be obstruction in that area. Once you remove the whole of the thyroid, it will immediately collapse. So that is why both the X-ray of the neck, AP and the lateral has to be done. Now, third was about the parathyroid. You know, apart from doing all those things clinically, you can inject the patient with methylene blue to find out the parathyroid, or you can use the ICG for that. Indocyanine green can be used if you have any doubt about that. And definitely you can do, if you have removed a piece of the parathyroid, then in that case you can put into the glass, what is called a glass test. If that tissue, it floats, it is the fat. If the tissue remains in between, it is a normal parathyroid. And if it goes down, sink at the bottom, it is the parathyroid adenoma is there. So by that, you can also find out that are you dealing with a fat tissue there or it's a parathyroid tissue.
Yes.
But otherwise, it was a good presentation, good discussion was there. Thank you.
Thank you, sir.
Thank you, sir. Thank you, Dr. Suyash. Thank you for
Thank you, sir.
joining us. Give our regards to Professor Bhatt sir, Sriram Bhatt sir
Yes.
also.
Okay.
Thank you.